All right, everybody. Nice to see you today. I'm Chris Carrubba. I'm a medical director at TrueLearn. And today I have with me Lindsay, and we're going to be doing a USMLE Step 2 shelf exam question breakdown for you guys to show you a little bit, not just clinical knowledge, but some of the test taking skills that you can use to do well on these exams going forward. Lindsay, do you want to introduce yourself and say hi?
Yeah, definitely. Hey, everyone. My name is Lindsay. I'm a fourth-year medical student. So I was in your shoes very recently, so I understand what you're going through, and I'm excited to get started.
And Lindsay's interested in OBGYN, so I made sure to pick a question that was not OBGYN, since she still has to do some other stuff every now and again.
Be better for it.
All right. So big thing for me, I always like focusing on test taking skills with students. And, there's certainly questions that you can, answer with no, real skill thought to it. But I think it's always better when you can go through and really learn a good process. That's what's going to carry you through on harder, more challenging questions. And I think for me, where I see a lot of people go wrong is they tend to be very passive about how they approach questions. And, for me, that means they start at the very beginning, they read to the end, they look at the answers, and only then do they start thinking about what's right, what's wrong. And I think for a lot of students, I find that goes wrong because they tend to focus on maybe one or two or, even three details, and they end up glossing over something that's really important. So for me, I tend to have people to, ask them to look at the last sentence first, consider the answer choices that are there, and then think a little bit more as they read through the question sentence by sentence. So Lindsay, starting on this one, we see that the kind of ending statement here is, in addition to encouraging the patient to maintain moderate activity, which is the following is the most appropriate next step in management. So to me, that means I'm going to probably have to make a, presumptive diagnosis in this STEM and then know how to manage it. When you're looking at these answer choices, do any common denominators jump out? Can you maybe get a feel for where this question might be going?
Yeah. So, in addition to the maintaining moderate activity, it's looking like a back pain, definitely, with all the different answer choices, MRI of the lumbar spine, different pain relievers, some things like that. We have some pain relievers. We have some that are further testing, imaging as well. So it's looking like whether or not we should go further and with the diagnosis. But what's sticking out to me with the question is encouraging the patient to maintain moderate activity. So it looks and feels more of a conservative management. So I'm going to keep that in mind too when I'm reading the vignette.
Absolutely. So I think my thought process going in is, step one for me is figure out, do we need to do more testing or not? If the answer to that is yes, what test should it be? If the answer to that is no, what kind of management? So I know I'm probably going to have to be on the lookout for any red flag features in the history and the exam that would prompt that testing. And if those aren't there, then I can move more towards the management pathway. So I'll let you get started reading, and, I'll interject at a point where I think it's good to stop and talk about things.
All right, sounds good. Let's get started. So a 55-year-old man comes to the emergency department due to 2 days of lower back pain. So looking at that, it's the ED, he's an older man and has some back pain. The pain began one day after helping his son tile a bathroom in his home. His pain improves with rest and heat, but is still present with ambulation and partially limits activities. Okay. There's no recent history of trauma, and he does not have fever, weight loss, lower extremity weakness, radiation of pain, or acute urinary symptoms. So this sentence for me is really important because it kind of addresses all of the red flags that could possibly be involved with back pain, like metastasis or like a cauda equina syndrome or something like that. And that's saying that he's not having these.
Absolutely. Not seeing fever. I'm not seeing weakness. I'm not seeing any of that stuff that would really make me, go down that diagnostic pathway here.
Then his medical history is significant for type 2 diabetes, chronic kidney disease, hyperlipidemia, and peptic ulcer disease. Okay, so he has a few comorbid conditions. Current medications include metformin, lisinopril, atorvastatin, and omeprazole. He does not use tobacco, alcohol, or illicit drugs. So that's important when it comes to...
At this point, as a pause, do you think you're going to end up going more diagnostic or management at this point?
It feels management for sure.
Absolutely. And I would still keep an open mind, right? Like there's a chance that you're going to show me something on exam that would change that. Maybe there's like very prominent vertebral tenderness, or maybe he does actually have weakness or hyporeflexia or something that might change that. But I would kind of say at this point, it certainly feels more like management.
Right. Yeah, definitely. His vitals are within normal limits, which is reassuring, and BMI is 30. The patient appears comfortable. Examination shows tenderness in the left lumbar paraspinal muscles. There's no tenderness to palpation over the spine, and straight leg raising test is negative. Range of motion of the lumbar spine is normal. Lower extremity strength, sensation, and deep tendon reflexes are normal and symmetric. That's a very good sign. His gait is normal. And then leading up to the question, in addition to encouraging the patient to maintain moderate activity, which of the following is the most appropriate next step in management?
So I think, again, we have enough evidence here to say that going down the, diagnostic pathway is unnecessary. There's nothing that makes me think infection. We don't need to do a CBC and, ESR. There's nothing that makes me think this is like some really bad structural pathology or, metastasis. So I think at this point, we kind of know we're not thinking about B and D. And one thing I always like to tell students to try to do on these kind of management style questions is to almost make it more direct. So like for me, in my mind, I'm saying like, this question is asking me how to manage an acute paraspinal muscle strain. That's what we're dealing with here. You have 2 days of acute paraspinal muscle strain. And, in addition to that, maintaining moderate activity, where would you go from there? So thinking about initial management of that, we have acetaminophen, low-dose opioid, and NSAID. Again, I tell people don't rush to pick an answer. And I think your first step would really be saying, do any of these seem wrong right off the bat? Do any jump out to you as being wrong?
Yeah. So, okay, we already ruled out B and D. C is jumping out as wrong. I think of opioids more in the context of a chronic back pain, where there's even like the muscle relaxants, but I don't think that 2 days of lower back pain following, physical activity warrants opioid prescription.
And I tell people, like, I would be cautious on ever having a blanket statement. I'm never going to pick opioids, because I think there are questions where I've seen where it's just like an acute fracture and they're in horrible pain and they're testing you that there are some appropriate uses. But when you're thinking about something like this, absolutely not. It's not going to be an opioid here. So I'm left with, at this point, acetaminophen and, NSAID as my answer choices. And, from a clinical perspective, I know that both of those are viable. NSAID is kind of preferred, but it's not that much of a preference. So really what this tells me is there's probably going to be some detail in the question stem that would have made one of these answers better than the other. So you had mentioned earlier that there were a lot of comorbidities in there. Does that influence your answer in this question?
Yeah, I think that if I was taking this on the test, I would have gotten to these answers and I would have been like, what? They could be so interchangeable. But then that would have prompted me, exactly like you said, to revisit that medical history, because what's jumping out to me right now is that chronic kidney disease and peptic ulcer disease are going to be contraindications to the NSAIDs and would make me lean more towards the acetaminophen.
Absolutely right. And there's other places they do that. Acute management of gout is one that comes to mind. I mean, I've seen a lot of questions where you get to the end and indomethacin and colchicine are there. And, they're both, I've seen say, well, they're both there. How do I pick? You look back and then you notice, hey, the patient has really bad peptic ulcer disease. Okay, that's a reason to go with colchicine instead of indomethacin. So that's kind of my process there. And, where I see students mess up is they just, NSAID's first line, I'm going to go with that. And they don't have that moment where they think and say, well, hey, wait a second. Is there something that would change this, for this specific patient? So that's kind of why I like more of that just standardized approach. And that would be the takeaway that I would have, for anyone on this, is that even if, this specific question felt easy for you, I think you can always build standardized approaches that will help you get more questions right when it does become hard. And it's going to help you get questions right when there might be some trick that's there that is going to mess you up if you are rushing through. What would you say?
Yeah, I mean, I lived it going through countless blocks where I would be, wanting to speed through a little bit, and I would go through and I would get a question wrong because I would have just jumped to, oh, NSAID's next. And then I would have gone back and read the explanation and been like, oh, if I would have just taken the 2 extra seconds to, contemplate back and forth between the two and revisit that question stem, I would have been able to find that answer. So I think that having, a go-to system where you're like, this is my approach, this is how I'm going to do it, and sticking to that is going to completely remove a lot of mistakes that could be completely avoided.
Again, for when you're on your own doing these questions, I think that's what you do. If you miss a question like this, go back and say, hey, why did I miss it? And if you notice, hey, I just didn't have that moment where I look back at the comorbidities, then just make a rule for that going forward and say, hey, okay, next time when I see any treatment question like this is going to be my process. And I think when you build those out, even if it's taking you more time on the front end, maybe it makes you a little slower right now. Maybe it makes your studying a little bit slower. It's going to pay off in the end. And that's, how somebody's going to go from, barely passing to a very high score, without making too many, groundbreaking, difficult to achieve changes. So thank you for your help today. I'm glad we could do this, and be on the lookout for more of these videos.
Thank you. Take care, everyone.